That's a good segue into the third imperative, which is controlling healthcare costs. And we kind of switch now into the practical effects on the federal budget. The healthcare cost is the driving factor of long-term budget growth and what we sometimes call the unsustainability of the federal budget. When you look at it, healthcare costs are the fastest growing component over the longer term. So let's, beginning with that, just sort of sketch out about where we are, why that is, the magnitude of the challenge fiscally with healthcare costs.
Well, looking out over the next few decades, there are you can break out the growth in spending into two components. The first is the aging of the population. As we've already discussed, rates of chronic morbidity rise along with age. The elderly consume more per capita in healthcare services than the non-elderly, a lot more. The elderly are the fastest growing segment of the population. The older the elderly are, the more healthcare they consume, and the oldest elder age brackets are the fastest growing of all. So you put all of these multipliers together and you get very significant upward pressure on healthcare spending. According to the CBO, about 2/5 of the increase in total federal healthcare spending between now and 2050 is due to the aging of the population. The other 3/5 is essentially due to the rising cost of what everybody consumes in terms of healthcare services. And you can think of that, it's sometimes called excess cost growth. And excess cost growth refers to the extent to which per capita healthcare spending, adjusting for demographic change, is rising faster than per capita GDP. And that excess cost growth is driven by technology, new tests and treatments, by the increasing cost of the labor required to deliver that technology to patients. And by rising public expectations about what the healthcare system should deliver in terms of health. Good health is a moving target, right? It's not a fixed standard, and it rises over time as societies become more affluent. So all of that is driving up healthcare spending faster than the economy, which is why healthcare spending is projected to rise both as a share of GDP and as a share of the budget.
Two of the issues that come up when this gets discussed in a policy sense are the, because you mentioned that healthcare costs, excess healthcare cost growth is high. It's higher in the United States than it tends to be in other countries. And so people point to two things. One, improved healthcare, improved health status of the elderly, and say, well, maybe if as we're aging, people are more healthy, that would help control the overall cost growth. Second is there's so much waste in the system. If we could root out the waste, some estimates as high as 30% of healthcare cost is, waste or inefficiency. These two things would avoid having to make any difficult choices about our current healthcare delivery system. You deal with that in the paper.
Yeah. Well, on the first one, will improvements in the health of the elderly tend to slow healthcare cost growth? I'm skeptical about that, and the main reason, or a main reason, is this distinction I made earlier between disability and morbidity. Rates of disability have declined among the elderly, but rates of chronic morbidity haven't. And it may well be that rather than declining disability leading to lower spending, it may be that rising spending is leading to declining disability. And also, if you look across countries, across developed countries, there are very significant differences in healthy life expectancy at age 60 or age 65. Yet the ratio of spending on the elderly to spending on the non-elderly is similar, surprisingly similar across all of the developed countries. So other countries spend less, but they don't spend less on the old relative to the young because the elderly are healthier. So that puts the burden on this excess cost growth. And that, in my view, requires real cost benefit trade-offs, which brings us around to the second point, which is the argument that those trade-offs are not necessary because there's so much waste in the healthcare system. Well, there undeniably is a vast amount of inefficient, ineffective, and hence wasteful care. And as you noted, and this comes from work by scholars associated with the Dartmouth Health Atlas project, as much as 30% of total national health spending may be waste in the sense that it is inefficient and ineffective. Or to put it another way, if everybody followed best practice guidelines, we could save almost a third. But 2 points. It is one thing to statistically demonstrate across the entire population that X, Y, or Z is the best practice. And it's another thing to say that best practice is necessarily the best practice for any particular patient at any particular point in time. Those are entirely different things. The first may be true, the second is not true. And so enforcing best practice guidelines would ultimately mean that some people have to give up some care at the margin that is beneficial. Furthermore, even if you could painlessly eliminate all of the pure waste, that wouldn't necessarily change. Yeah, you'd save, 3 or 4% of GDP. That's an enormous amount of money. But you wouldn't necessarily change the growth trajectory because, again, it's driven by technology and expectations. It's not the proliferation of waste that's driving the growth, even though the waste may account for a big chunk of the level.
So that gets to the last point here on the healthcare point, which is the lack of any budgetary constraint to force these choices, even to force out the waste. We have an open-ended system, fee-for-service Medicare. We have a lot of subsidized, tax subsidies for larger healthcare, more generous healthcare costs. So a lot of the incentives are built in to spend more and not worry about the cost constraints. And a lot of other countries that have these better results or have universal healthcare also have much tighter controls on what can be spent on healthcare for patients. So talk a little bit about the need for some sort of restraint on the overall system.
Well, that's what is often fundamentally misunderstood about national healthcare systems, and they come in many different types. Whether it's the government itself that runs the healthcare sector, as is the case in the UK, or whether it's just government reimbursing private providers, as it is in most continental European countries, as you suggested, Bob, they all have some sort of budget. They budget for healthcare. We don't. And they have mechanisms to enforce the budget. We try to do it. It's either controls on the price or the volume. Volume meaning how much technology of healthcare services. And they may just be on the hospital sector, or they may be, a global budget for the entire healthcare system. But in one way or another, to one extent or another, other countries spend less because they put constraints on how much, effective constraints on how much is spent. So we've got our foot on the gas, and then we're, it's like pressing on a balloon, right? Then we're trying to control, we're trying to control Medicare spending through, prospective payment and DRGs in hospitals, and it pops up in the outpatient setting. We're trying to control it even as with one, on the one hand, even as we're fueling it on the other hand. So it's not that large savings in healthcare is not feasible. And it's not that it's not that it will require enormous sacrifice either, but we need to acknowledge that there have to be cost-benefit trade-offs, and there has to be a mechanism for imposing those. And the debate should be about how to set the limits. What's the most effective and efficient way? Should it be top-down regulation? Should it be, capitation and premium support? Where the government gives each beneficiary a set amount of money to purchase insurance. In other words, it budgets